So, hi everyone, I'm Lajos Kemény, the editor-in-chief of the International Journal of Dermatology. My guest today is Professor Aditya K. Gupta and Tony Wang. But let me first introduce Professor Gupta. Dr. Aditya K. Gupta is a dermatologist with approximately 35 years of experience and with more than 900 publications. With the H-index, extremely impressive, over 125. He earned his medical degree from the University of Southampton, UK, followed by dermatology residency and clinical research fellowship at the University of Michigan, Ann Arbor. He also holds a PhD from the University of Göteborg, Sweden. He is a professor of dermatology at the University of Toronto Terminal Faculty of Medicine and the principal investigation at Mediprobe Research Incorporation in Canada. He has established and led active clinical trial units in London, Ontario, and direct research team. His clinical research focuses on superficial fungal infections, onychomycosis, tinea pedis, tinea capitis, hair disorders, as well as psoriasis, atopic dermatitis, acne, actinic keratosis, and skin cancer. So, hey, Aditya, welcome you in this podcast episode. And I would like to ask you to introduce our guest, Tony.
So Tony is on my research team, and we have published a lot of papers together. And later on during the podcast, we'll be discussing a couple of papers, and I'm hoping he can add some more detail to some of the papers because he has a special interest in those topics as well.
Yeah, thank you. It is really great that we can have a younger colleague among us. So, at first, let's talk about our journal. You are one of our recently elected associate editors in the International Journal of Dermatology. Could you please share a few words about your motivation to join the IJD as an editorial board member and as a section editor?
So, I had exposure to the International Journal of Dermatology for many years, ever since I was a resident in dermatology. And one of the things I enjoy about the International Journal is that it has got a very diverse and international readership. It attracts publications from all over the world, not only North America where I live, but obviously Europe, Asia, and Africa. And it has got some very interesting material that's of interest to us because of its wide exposure. It emphasizes up-and-coming dermatologists, so those who are perhaps in early stage training, and even medical students or dermatology residents. And it's good to learn and read about what they have to write, because sometimes they've got very interesting observations. There's got a diverse set of topics. Dermatology, as you know, is a very, very wide field, and with newer things coming up, such as devices and artificial intelligence, it draws upon even a wider field now than it did before. I have been a contributor since my very early days. In fact, even before I entered a residency in dermatology, some of my earliest papers were published in the International Journal of Dermatology. And I truly like writing for the journal because I think my work will be reviewed by a very, very diverse audience.
Yeah, really, thank you very much. And having seen your excellent publication record, what is your opinion? What is in dermatology is the field that have seen the most significant developments?
Yeah. So I think one thing we can talk about is perhaps the skin of color, is the recognition on how we treat patients who have skin of color. When I trained in England, very early days, and obviously I've been brought up a very Caucasian population. The presentation of skin disease in patients who are fair-skinned versus dark skin can be quite different. And with dark skin, some of the presentations can be more challenging, as we all know. and also my other area of interest, which is hair disorders. We find that the patients who got skin of color have got a different sometimes have a slightly different presentation. We all learn to adapt, and in order to best treat the patients who come to see us, we have to become better at recognizing different presentations of the same disease, perhaps in skin of color. The other developments in dermatology basically are newer therapies. For example, when we look at androgenetic alopecia, which is something I've become interested in, we recognize that there's an interest both in the prescription therapies, which are what I would call FDA approved, which would be, say, topical minoxidil and oral finasteride. But beyond that, there is obviously an interest in other topical medications, such as more recently topical finasteride, which is approved in some parts of Europe, for example. There's no standardized therapies for North America for topical finasteride. There's interest, obviously, in Dutasteride, which would be off-label for androgenetic alopecia, which perhaps our work and that of others has shown is probably more effective and probably very similar side effects profile than oral finasteride. So that's so treatments have changed. There's the introduction of platelet-rich plasma and exosome therapy for androgenetic alopecia. So newer treatments come along. Same for alopecia areata, hidradenitis suppurativa. There's targeted immunotherapies for adults and children, and the same goes for immunotherapies, if you would, for atopic derm and psoriasis. So it's a very, very expanding field. And if you look at changes even from year to year, or certainly even the last 5 years, and the International Journal of Dermatology has done a great job in trying to bring all these to the readership. For me, the other issue is obviously antifungal resistance. I have a special interest in antifungal agents and fungus. And in the last few years, we recognize there's increase in antifungal resistance, if you would, both in terms of antifungal resistance for toenail disease, which is onychomycosis, in the form of squalene epoxidase gene mutations, which would lead to perhaps an increased resistance to terbinafine, and more importantly, or just as importantly, for newer species have come forth, if you would, like Trichophyton indotinei, which is almost completely resistant to terbinafine, and so we have had to look elsewhere. Now, these are important conditions where, for example, I hear from my colleagues in India and elsewhere that large populations have Trichophyton indotinei, which is a chronic infection of the skin, fungal infection, and when you have no good treatments or treatments that fail therapy, so that becomes an issue.
Yeah, and now we arrive to the major part of our discussion. You published recently 2 excellent papers, and one of them received the highest number of downloads in 2025. That was about Finasteride topical or systemic route that you already mentioned. Could you go into a more detailed to this paper? What were your major findings in this paper?
So basically, we recognize that when we're looking at androgenetic alopecia in particular, which is male pattern baldness and female pattern baldness, certainly for males, we have treatments such as you know, topical minoxidil, but more recently oral, but finasteride, which is FDA approved for male pattern androgenetic alopecia. Now, there are associations with this condition. For example, there's the neuropsychiatric associations of perhaps depression and suicide, to mention a few. There's also associations with the genital and psychological side effects such as erectile dysfunction, loss of libido. And the question really becomes is how prevalent it is, and we really don't have a good sense of how frequent the association is. But there is the FAERS database, which is a database where both patients, physicians doctors and others can report the side effects, and then these can be tabulated, and it's an open database for everybody, and then we get an idea of how often perhaps the side effects are with oral finasteride versus topical finasteride, and then oral dutasteride versus the topical dutasteride. This is important to us because to see whether topical finasteride may have side effects, because one of the reasons why people gravitate or want to use a topical formulation is that the thinking that obviously you have a lot more safety in terms of both neuropsychiatric and urogenital side effects, but then there's the efficacy on the other side of the equation, right? So we found that certainly with topical finasteride, there's far fewer side effects, but we were happy to see that there could be a placebo or nocebo side aspect to it, that people are associating some of the side effects with the oral formulation with the topical formulation, or it could also be that with the topical formulation, there's enough absorption, if you would, into the bloodstream. So this is an interesting paper from that point of view. We found that with topical dutasteride, there were no side effects, but that could be perhaps because, firstly, topical dutasteride is not used as often, but it also could be that people are not associating dutasteride with side effects like they do with finasteride. All in all, it's a very complicated issue. There's a lot more to it. We're still trying to learn about it, but it's only through studies such as this, which compare the oral versus topical, do we get a better sense of what the relative efficacy would be, the safety would be of topical finasteride versus oral finasteride. And more recently, in the international journal, not our group, other groups have published on topical finasteride in terms of efficacy. Now, in terms of, we had another paper that we wrote on climate change. And what I'm going to do is Tony, who works in our group, has a special interest in this. So I don't know, Tony, would you like to talk about that?
Yeah, Tony, please.
Thank you. Thank you for this opportunity to talk on this topic. So climate change, as we know in the general sense, can involve rising global temperatures and changing weather patterns. So just as Dr. Gupta mentioned earlier on the topic of trichophyllene endotheliae, another one of our research focus is really on superficial fungal infections, commonly known as tinea or ringworm. In this review, we asked the question whether dermatophytes are sensitive to the effects of climate change, and do we see any changing patterns in terms of its epidemiology? This type of fungi are sensitive to temperature and humidity, and their regional prevalence may fluctuate per those patterns. Most fungi, in fact, more than 99% of fungi do not cause human infections, precisely because they grow typically within the range of 12 to 30 degrees, which limits their ability to survive in the human core body temperature of 37 degrees. However, with rising global temperatures, some environmental fungi may gradually adapt to higher temperatures.
Yeah, thank you very much. It's really climate change has many different effects on our skin, and there are many different diseases that occurs more frequent and new pathogens occur. So this is really a great work, and congratulations for your work. And thanks for publishing in the International Journal of Dermatology, because these two papers received really a high attention. In Hungary, actually, we are in a lucky position because we do have topical finasteride, and we have really good experiences with that. But going back to the research, and Professor Gupta, what is your opinion about the major challenges in dermatology, in research and in patient care?
Well, this is a very, very wide field, but let's just pick on a couple of things at least where I kind of have a special interest in. So I thought one was reliable diagnostic testing. And for me, it would be kind of more fungal infections, if you would. And we're going to just talk about that, but make the point. Certainly infectious diseases in general, and also dermatology, we need to have a proper diagnosis. And in the absence of diagnosis, clinical diagnosis only takes us so far. But in many, many cases, especially if you're going to prescribe oral agents, some of which may have side effects and can be even severe side effects, it's important to have the diagnosis. And then and only then, and for some patients, whether it's being covered through insurance or they're paying for out of pocket, it just would not be fair to be treated with an agent that was for a wrong condition. So, for example, I'm just going to go back to onychomycosis, which is often, it's only about 50% of the cases that are abnormal appearing have fungus. And this is work we did about 25, 30 years ago, and others have done that have shown certainly that a large proportion of patients with abnormal appearing toenails may be due to trauma, psoriasis, lichen planus, and other conditions, but not onychomycosis. So getting a good diagnosis, but the issue is obviously more to it than that, because the tests we use, the traditional tests, light microscopic and cultures, certainly the cultures can often be negative and they take a long time. So there is now access to more advanced testing, such as molecular testing, which can produce results that are more accurate and faster. But obviously a downside is that they're more expensive and they're not available for individuals in all parts of the world, which is what we have to be aware of. This then leads us to trichophyton endotheliae that I spoke about earlier, and there the KOH culture are not able to distinguish from, say, trichophyton mentagrophytes or trichophyton rubrum, and so therein lies the issue that the traditional testing would not be helpful, and therefore we have to resort to more advanced molecular testing, if you would, in the form of gene sequencing or even PCR testing. So these are some of the issues where the challenges for us in dermatology is that the inequities, if you would, of the availability of diagnostic testing across the whole range of diseases. And like I said, for trichophyton endotheliae, I talked to my colleagues in India. The condition is so prevalent that they cannot wait for the tests to come back. Firstly, it's difficult to test large populations, if you would, with molecular testing. And number two is the time taken for the turnaround. So they have to treat on an empiric basis, but keep in mind the underlying thought process is that diagnosis is essential if you're going to know what we're treating, not only for fungus but for other conditions. The other challenge we have is a limited armamentarium of drugs that are available, and we find more and more, certainly when it comes to resistance, and I'm now going to take it back to antifungal resistance. We find that terbinafine, which was our drug of choice, may not be effective, and itraconazole, increasingly itraconazole azoles, may not be effective in some cases. So therein lie the challenges of using drugs such as posaconazole, voriconazole, which have traditionally been reserved for systemic mycosis. And so there we have to be careful of antifungal stewardship as well, because if you start using these agents, which are all the more powerful and more effective, perhaps, but they've got more side effects, and also it's only a matter of time through use that antifungal resistance develops. It's a well-known fact through history, be it through ketoconazole, terbinafine, itraconazole, fluconazole. The more we use these drugs, sooner or later resistance develops, and then it becomes an issue. So then we are caught at the crossroads between using these newer antifungal agents and prospect of antifungal resistance developing, which would even more limit the armamentarium of drugs for systemic mycosis, which is where they're truly needed. So those are issues we develop. Now, there are certain diseases such as alopecia areata, if you would, psoriasis, atopic dermatitis. We have a lot of newer agents that have come through. So perhaps this is less of an issue, but certainly for mycology in my space, it is something that we need to be aware of and we need to think about. So perhaps those are the things that I had in mind, Dr.
Yeah, returning back to our journal, we have to face with increasing number of submissions. In the last year, we received close to 5,000 manuscripts to deal with. And this is a lot of work for the editorial staff, for the editors, for the reviewers, and of course the authors expect a fast and quick and proper review. So this is something that is not easy to handle. Publishing industry is very important for all the players. What is your opinion on this increasing number of submissions and the overemphasis of the impact factor?
We have to publish to kind of stay in front of the field. Otherwise, you gradually disappear. Time from submission to acceptance or decision is about 60 days, which is incredible because there's so many articles, and I frankly don't know how you guys do it. It's incredible.
With your help, it is very easy. The answer is very easy. With your help, you were the fastest reviewer actually, and this was one of the reasons why we invited you to the editorial board as an associate editor. Everything depends on us. We are all the same person is an author, and then we are also reviewers and we are also editors. So I think that depending on in which position we are currently, then our attitude could be different. Frequently we invite a reviewer and would say no way, and the second day he will send us a paper, and after 1 week we got already an inquiry what is happening with his or her paper. So but we are doing our best. So at last, what would you suggest for young dermatologists to be involved in research? Yeah,
the expectations can be sometimes misguided, if you would. It is important for us, for our journal, to be able to identify and attract and keep individuals who are happy to able to help us with the editorials duties, because without them, obviously, you cannot be there sending papers out to multiple reviewers and have them turn down and keep this thing going. Have an interest in the review process and learning more about it, to volunteer for the journal. It is an extremely satisfying job. I think one way is to set limits with the journal, to say that I can only review, say, 5 papers a week, or I can only review 3 papers a week, or 1 paper a week, so that you don't get overwhelmed. But if you can contribute as well as submit papers, that's good. And then for junior individuals, I think it's a very satisfying job. You learn a lot by reading what others have written, and also how they've written, in order to improve your own skills by seeing what other individuals have said, how they've said it.
Professor Gupta, thank you very much for sharing with us your thoughts. Thank you very much, Tony, being here, and thank you for joining us today.